Yeah. So my name is Joe.
Joe.
I'm his dad.
Okay. And may I know the name of your baby?
Yeah. So he's called Freddy.
Freddy. Okay.
Yeah.
So, Dad, I'm going to examine his chest. And hello, Freddy. How are you?
Yeah. I'm good. Thank
Okay.
you.
Is it okay if I examine your chest?
Yeah. That's fine.
And if you are feeling any
Sorry. Sorry to interrupt. I'm just recording this session. Is that all right for everyone? Yeah.
yeah, yeah, sure.
Okay. Fine.
Okay. So, Freddy, if you feel any discomfort or pain while examining, so you can let me know. Okay.
Yeah.
Okay. Yeah, I know you are a strong boy. So I will start first of all with like the inspection, overall inspection of the patient. I will see whether the child is having any dysmorphic features, how is overall growth, or any oxygen like cylinder or anything or any other equipments are
So
present.
yeah. So there's no medical equipments, no medications, and the
Okay, no
child
dis.
looks well. Child looks well, and
Okay,
there's no
and overall
dysmorphia.
height and weight. I would like to see how is overall growth
Yes.
like.
So the child looks well grown. The height is at 50th
Okay,
centile and the weight is
then
at 25th centile. Yeah.
okay, so I would go into the chest and I will inspection. I will take the respiratory rate and I will see is there any pulsations, any visible veins, any scar marks, or any work of breathing.
So the respiratory rate is 26, and there is no uh, scar marks, visible pulsations, or any increased
Okay,
work of breathing.
okay. Then I will move on to the palpation and I will see the trachea, whether it is in the like midline or slightly on the right side, whether it is shifted or not. I will do the on the palpation. I will check the apex beat, whether where it is located,
Yeah.
and I will also check for the vocal phlegmitis. That is, I will say him to like say 3333. Like I will be doing it on like I would be comparing on both sides, on the right
Fine.
and on the left. Okay,
Yeah. Yeah.
and then after that I will go for the percussion, and
Okay.
percussion I will tell him that I'm going to percuss it on my finger, but if he gets pain or anything, then like Freddy, if you feel any discomfort, I'm just going to check you, and if you feel any discomfort, just let me know, and then I will start percussing from the right side, and then I'll compare the both sides, like
Hmm.
what is the toe like resonant, whether it is resonant or whether it is
Yeah.
dull.
So your
Yeah.
percussion findings are normal, normal on both sides of the chest.
Okay, percussion findings are normal on both sides of the chest. Okay, I will also percuss like I will also see the liver edge as well. Where is the liver? And then after that, I will go for the auscultation. I will auscultate on both sides and compare on both sides, on the front and on the lateral side. And also I will check for the vocal resonance with the stethoscope on front.
Hmm.
And also I will also measure with percussion. I will also measure the liver size as well. And then I will go for the and then I will go I will check the after completing my auscultation. I will check quickly the feet and like for any edema or anything, and then I will ask him to can he like turn his back towards me. Then I will do
Yeah.
the quick examination of the back because most of the respiratory findings are found on the back, and then I quickly examine the back. Is there any scar mark or anything? Or then uh, I will do the vocal phlegmitis, but I think quickly, and then I will do the percussion, and then I will do the auscultation and the vocal resonance,
Hmm.
and meanwhile I will also check for the cervical and the axillary lymphadenopathy. I will ask,
Hmm.
and then I will see his hands and eyes for anemia, and also hands for the clubbing, then eyes for the anemia, and then what else? Yeah, I would like to offer because I think respiratory examination is the most lengthy examination because you also have to check from the front and the back. So if I would not get time, I would like to say that I would like to do the ENT examination as well.
Yeah. So
And
when you do the ENT examination, you see some nasal discharge in the nose.
nasal discharge.
Yeah.
Okay. And what color it
And
was?
there is no pallor, there's no clubbing.
Okay. Okay. And I would also take the full, like, ask whether he's having temperature or what are the, like, I would
Yeah,
take
so
the heart rate, and if he's having
his observations are normal, and sometimes they might give you a handout of chest X-ray film, or they may not, but that's also normal.
okay. Okay.
So yeah.
I
So
think that would
yeah,
exactly
fine. So it's nearly time as well. It's another 10 seconds. So would you like to summarize your examination findings, and what are your
I would cover him, cover him, because I have taken his shirt off, and I would thanks the patient, and then
yeah.
I would tell the examiner that this is a 4-year-old boy who seems to be well grown, with no dysmorphic features, and I would like to plot his height and weight on the centile chart, and he's having a normal respiratory he was having a normal respiratory rate, no signs of any respiratory distress. Vocal phreatus was normal, and the trachea was in the central place. Apex beat was in the fourth, and like whatever it was, fourth intercostal space and medial to the mid-clavicular line. And on auscultation, uh, bilaterally equal air entry and normal breath sounds were present, and vocal resonance was also normal. And there was no cervical lymphadenopathy, and no anemia or clubbing, edema, or uh, uh, or anything was found. No
Mhm.
any scar marks or no prominent veins or pulsations were found.
So
There was just a
what are you thinking of? What do you think is going on?
uh, he is presented with a chronic cough for 3 weeks. So sometimes the cough, because as I have seen the nasal discharge, so sometimes it could be a post, like he could have a rhinitis. So secondary to that, he is having post nasal dripping that is leading to the cough. And sometimes the cough, it takes time to settle, because overall his observations are fine. He's not running fever, but I would like to take the complete history in order to miss any chronic infection. Like I would like to check for whether he has been traveling to any TB endemic area, or like any contact with a chronic cough, or what's the family history. Is there anyone who is
But
having?
why do you think he has a chronic illness like TB? What makes you think that?
No, not at this point of time. This could be because sometimes in the children the cough takes long time to recover, although the
Yeah,
overall they are fine. Sometimes it is a nasal discharge, or because of the allergies or things.
yeah,
This could be the one of the reason,
yeah.
and sometimes takes long time. But I would like to take the history in order to not miss anything.
Okay. What in this particular child, based on your examination findings, is there anything else, or and in terms of management, how would you proceed with the management?
In terms of management, I would also ask about the nighttime symptoms, daytime symptoms, use of salbutamol inhalers, and any activity limitation, because chronic cough with no obvious silent symptoms can one of the cause of like asthma could also present like this, and also a family history of atopy. And also
Mm-hmm.
I would like to see eczema, which I think missed, because sometimes the child
Yeah,
who are having eczema, they
yeah.
can
That's
also.
that's fine. Yeah. So how would you manage this, and how would you address parental concerns who has come with three history of 3 weeks of cough, and the child has completed antibiotics, and if they ask, would you be offering them antibiotics again at
Uh,
trial?
No, I would not give them the trial of antibiotics. I will ask them to write the symptoms, and I will give the safety netting advice. And depending upon the history, because history in this case is very important. And if he's having asthma, or if he has a good, I can offer a salbutamol inhaler, and see like how does. Although he's not having presently any symptoms of bronchospasm, but if he has having at what time the cough is occurring more, like at the day, like at the early morning or in the night time, so does he get relieved by those inhaler? So I would like to see the response. And
Okay, fine.
other than that, I
So
will also ask about the vaccination of influenza.
Yeah, that's fine. But okay, so it's I think it's already beyond time. Um, so yeah, I think it was overall. I mean, you've done a good management discussion. What was your thoughts? What were your feelings with this examination?
I think I did okay.
Okay.
Like,
Any modifications or corrections can you think of based on our previous
because the
discussion?
chronic cough, so actually we are in UK, but our mind is in Pakistan, I think. Because when chronic cough came, so we think about tuberculosis, but here the children, mostly every four in one child is having asthma or allergic cough. So I should also be thinking, because it's a well-grown child, but so the TB was coming, like TB came in my mind first. So that was the
Yes.
thing. And
Yeah.
otherwise the child was well grown, so the asthma, allergies, like these are the most common things which occur here. So that should be
Right.
my top differential.
Yeah.
Other than that, I don't know how well I will perform live this thing, but
Look, as I said, you have a good sound knowledge of the theory background, but here, I mean, I would just like to give you some feedbacks. What
yeah.
you need to improve on, particularly.
Just wait. Does Myra want to say something regarding how how will Myra examine this child? Is there anything you would add or your approach?
Um, I think
We
I was
that's
just
let's say
thinking that I will start with hand because I was told that here it's
Right.
considered good to
Yes.
start from the hand. So I will start
Exactly.
with hand
Exactly.
examination, clubbing, and then I will go on the face and then look for any kind of signs of the respiratory distress like nasal flaring, tracheal tug, and
Yeah,
then the
yes.
inspection of the chest, and then I will just have a complete look on the body as the child is well on or unwell, dysmorphic facies as Aisha already covered,
Yeah.
and yeah,
Did
so
did
that's
Aisha
how.
wash her hands?
Yeah,
No,
also yeah,
no,
wiper.
I have not washed my hands.
Fine. So, can you guys see the screen share which I've just put on?
Yeah.
Yeah. So, if we, in the clinical domain, clinical station, so you have the physical examination where you have meet standard, um, and then this borderline, and then zero. Because your exam was like uncertain and unstructured, and a bit of poor adaptation to patient need. This will depend on how you have introduced yourself and how you have explained what examination you'd be doing, and you've adequately sought permission to expose the patient. If you rush into those things, you may be marked here zero. But if you have done those things because of lacking some structure, you may be given mark of. I mean, you may be marked here in this domain borderline. So it depends on how you would be approaching the patient. So that's very critical in all these stations. So be sensitive and try to explain, try to instruct what you're going to do so that the patient is, not um, caught off by surprise, or patient doesn't feel uncomfortable. So you would be probably just when you enter the room, you have seen those any things are looking around the patient which you have done. You have looked at the patient, and whatever points you have done, you do not need to verbalize or narrate it out to the examiner at that point. You can and then
Hello.
you can start with the building rapport with the, I mean, introducing yourself to the to the child, and then explain that. Or all right,
Baby
Freddie,
is already out.
can you hear me?
Okay. Okay. Do we need to come for that? Okay. Okay. If there would be anything, then please. Okay. Okay. Thank you. Bye. Bye. Sorry, I
Yeah,
got
no,
bleep. So yeah,
no,
yeah.
no, no, no problem. So yeah, so be mindful when you just enter the examination room, looking around the patient. You have done those things fine, but you do not need to verbalize that there's no oxygen cylinder or no medical equipment, so things like that. If it is not there, however, if you note something to be there, I can see a nasal prong, I can see a tubing or NG tube. You can make a
Mhm.
note of that. You don't need to verbalize that at that point because it will be obstructing your flow of examination. This will be
Okay.
in your summaries, and then you build rapport with the patient. Hi, Freddie, this is so and so, and I'll be just doing a bit of listening to your chest. So I would like to I would like to take your shirt off and ask the dad that can I take his shirt off for the examination. get him seated, get him comfortable, ask him to raise his hands on top of his head, both the hands, and do your when you're this is when doing the chest examination. So you first start with looking at the hands, look for uh, look for the nail beds, specifically look for the clubbing, and especially in respiratory examination you have to look for any fluctuation of the nail bed, and try to look from the side so that you do not miss the Louis bone angle thing, and also try to ask the patient to do that diamond shaped thing to not to miss the obliteration of the nail
Shamrods.
bed angle. Yeah. So the
Yeah, we
examiner.
usually check the shamrods, but you are saying we have to check for the fluctuation as well.
So you start with the fluctuation, then you can do the shamrods. Either of the thing,
Okay.
you have to convince the examiner that you are looking for clubbing.
Yeah,
Okay.
basically you
Okay,
have
that's
to
fine.
convince the examiner that it's not about getting it right. You're just trying to show that you are trying to look for clubbing. It's like a driving test. You basically have to do like textbook, even though literally
Like
no one's gonna
you have to act
Yeah.
yeah.
to best.
And then look for peripheral cannulation marks. Okay, and then warmth of the skin, and then eczema, allergic shyness in the eyes, dysmorphic facies. ENT examination should happen then, not after
Yeah.
auscultation. You should not remember, oh, I forgot ENT examination. It
Yeah.
should come into flow. Otherwise, you can't go back, come again, and think of
Yeah.
the
So
years while examining.
in this instance, as
And
you
also, I think
jump
chest
from the
movements, do we do here? Chest movements or chest
Yeah, with the
expansion?
chest expansion with the hand, you should see.
Yeah, with the hand. Yeah.
Yeah.
yeah, you can put as a circumferential. If it's a small child, you can put your hands as circumference in the
Yeah,
chest,
yeah,
and
yeah.
you can see the expansion. And what you're essentially looking for is not the exact centimeter expansion. You're looking for any asymmetrical in
Decrease
the.
movements. Yeah,
Yeah.
on
Yeah.
either of the side. Yeah, yeah.
Yeah. So yeah, after the hands, you have come to the face. You have looked for pallor, and then you have looked for the nose. You also inspect the throat. Is also in this will be relevant.
Okay, so we will start with the ENT first, and then we will go for the chest.
Yeah, you start with the hands, face, and then chest. It's not the ENT system as such. It's the hands, face, and chest, and that is the norm of clinical. That is the structure of clinical examination here in the UK. And even if you read Wayne Harris and all the standard textbook of clinical examination here in the UK, that is the main difference from what we've been used to.
Yeah, we used to do the. Okay.
Ideally, you can also say like you could just say to the examiner, ideally I want to examine ENT, even though I don't have the devices to examine ENT. Just
Do they
add,
have
even though you don't have to properly look
otoscope
into the
there?
ears or anything.
Do they have otoscope there?
If they do not have, you can mention that you would like to complete your examination by looking at the ears using an otoscope.
Okay.
Okay, but if they do have, you can do that. So just now deviating away from the topic, if suppose if it's a cardiovascular examination, it is reasonable when you go in, and if the baby is small, and it's a small child or infant who may have a potential of crying. If the baby is settled, you can straight away listen to the heart, that the examiners are happy with it, unless and until, I mean, as long as you tell the examiner that I would like to be, I just want to be an to examine the child's heart while the child is settled, but then I'll come back to begin my examination again. The
Dr. Rice, in
Yeah,
Pakistan, we used to look for BCG vaccine mark. So, can we do
it's
it
it,
here as well?
it's not recommended because BCG vaccine is not a part of standard vaccine program here in the
Okay.
UK, so you will
Hmm.
not be finding that scar. But
Hmm.
if you do find the scar in a child whom you have exposed and you have actually identified, and you can see there's a BCG scar,
Hmm.
do make a point of that. That will give you an extra marks, but it's not
Okay.
a part of routine examination because that's not a routine vaccination here.
Okay.
Okay.
Hmm.
So face, neck, you will be looking for lymph nodes, supraclavicular, and just a superficial palpation of the neck. And then you proceed to the chest, and chest, as I said, ask the child to raise the hands on both the hands on top of the head, and do all your chest examination, front, sides, and back, um, at the same time. Like don't leave your uh, for example, you've done the anterior chest as she did, and then you turn behind. you do the full resonance and full percussion and auscultation again on the back side of the chest. Once you're doing it, try to do it once at the same time. Do you understand what I mean?
So you mean to say that if we are doing the inspection, we are doing from front, lateral, and back all together,
Yeah,
and then
yeah,
we go
yeah,
to okay.
yeah. Don't do inspection, percussion, and the auscultation of the front, and then do it again with the back. That is, you will be spending additional time, and that's also not part of the actual flow and structure of the examination as well.
Okay.
You might be missing findings. You may be able to miss findings if there's something on the lateral side of the chest, infraaxillary area, or the back side of the chest. It's easier to get that doing it all at once. Do you understand?
Okay.
So once you have done that, and then you uh, summarize. So in your summary, it was quite a lengthy summary that you may not have time to complete that, whatever you have described. Try to keep these points in mind when you're describing, when you're summarizing any case. Avoid putting out negative things in your summary unless and until it's very essential. For example,
Okay.
there is no dysmorphism, there is no lymphadenopathy, there is no this and that. It's not required. It's not ideal to describe a summary in that way. In this particular instance, I deliberately did not put much of science, but this is a potential exam case. I'll let you know that this is, although you
Dr.
have
Ray, sorry to interrupt you. I just want to ask one thing.
Mhm.
You were asking like first we go like when we are checking the like if we are studying from the hand and then we went on to the face for examination and then we should do the back examination first and then the front. You mean to say?
No, when you come to the chest examination,
Yeah.
so you are treating the whole thorax cavity as one thing, as one
Okay.
system examination. So
Yeah.
you start from your front, look at both the sides and look at the back as well. So try to
So
see.
like we have to make the patient sit in such a way like when we are inspecting from the front, then we are inspecting from the back as well.
Yeah, so you can move around and you can, if the child is seated
Because
in a.
in like Pakistan when we were doing FCPS, we used to like do complete first the front and then again doing the back. We haven't done like in one go front and back together.
No,
So that is
it's different here. It's, you can ask the child
okay.
to, ideally there will be a stool where you can easily maneuver, you can move around, you can move front and back, so to do those examination. I mean, this is a very I would say it's a very soft differentiation, as long as you are able to pick up the signs. You have done the structure from starting from the hand, face, neck, and then the chest. It's not a major deal. But what you did in your examination, you went to the chest first, and then you went back to the hands. You then went you back to the face, and then you went back to the neck. So that
Because
is
in
that is
our country we used to do for the command was respiratory, then we used to do first chest and then the relevant we do
Yeah. So
afterwards. But I don't.
yeah. So this in this instance, you will be marked in borderline if you have completed the rest of the 2 points. This will not be
Okay.
coming under structure examination. So just try to modify this in your approach and be mindful of your
Okay.
examination structure here.
Okay, that's fine.
Okay. And then yeah. So coming back to summarizing. So this is a well-grown 4 year. I've examined Freddie today, who's a well-grown child. And so the I think the positive clinical sign of a nasal discharge. Did you mention that in your summary?
Yeah, in the end I said.
Yeah, so that should come in the front. That should come in the. I mean, the positive clinical signs should be present right at the front after describing the general appearance of the child. That I've
Okay.
examined so and so who is well grown for his age, and on examination of his respiratory system today. Uh, and if you have identified something in the room around looking at the patient, so for example, if it's a small child with a nasal prong, or if it's a child with NG tube in situ, or if the child has come with medications or diuretics or things like that, you can say that I've also noted the child has so and so along with him. Okay, and then you start on examination of his on assessment of his respiratory system. There was a nasal discharge with normal nasal septum, and you will be looking for nasal septum deviation, nasal polyps, and things like that. And then any other positive finding if you find in your actual exam, mention those positive findings first, and then mention the relevant negative finding if it is appropriate, that there's no increased work of breathing and the child doesn't appear to be in distress. So and there's no clubbing or there's no stigmata suggesting of a chronic lung disease. So I would like to consider my differential diagnosis as a cough secondary to postnasal discharge, or allergic rhinitis, or a reactive airway disease like wheeze or asthma. As you generally do not label asthma less than 6 years. So you can mention in that order. And then in terms
Reactive airway disease or viral induced wheeze?
Yeah, wheeze associated lower respiratory infection as well. If there is a wheeze. And then after listing your differential diagnosis and then the examination, in this instance the examiner will ask you, would you give another course of antibiotic? The examiner will be checking you on that aspect, and you might get a chest x-ray film to comment on or to interpret on that. Okay, so I kept this simple in terms of mainly to focus on your examination part, how you'd be approaching, how would be doing your examination. But the cases you will come across in respiratory can be as simple as a nasal polyp or a nasal discharge, or it can be as complicated with a chronic bronchiectasis, cystic fibrosis, interstitial lung disease, and with a chronic lung disease in a young infant who is on oxygen, low flow oxygen. So things can be in any of these spectrum, but your examination structure should remain the same. Your summary, you have to practice your summarizing, how you summarize. Give the first initial introduction, general description, give the positive signs, and then give your differential diagnosis. Okay.
Okay, and what about if we are, do we need to say I would like to complete my examination by peak expiratory flowmetry or spirometry?
Yeah, those are also relevant.
Inspection and
but
saturation.
4 years old, they don't do it if you're in peak expiratory.
So
if the case is above 5 years old.
Yeah, in this instance, it doesn't actually qualify. You have not heard of wheeze. You've not identified anything that would suggest a reactive.
But if we get a chronic patient who is failure to thrive, who has clubbing and who is having findings in the chest, so we would like to say, right?
Yeah, you can say those things. So the closing
and
remarks.
I want to take the benefit. I would like to ask, if that would be a chronic case, so is it just enough? Like we will tell if it is a bronchiectasis, like if we find a creps and increased work of breathing, or it's like a chronic lung disease. So would we like to tell the differentials of everything, like congenital, acquired, and immunodeficiencies, like everything, cystic fibrosis, ciliary dyskinesia, CCAM, and acquired could be foreign body, like we will tell everything? Or how do we, what sort of questions they will ask, and do we give the generalized management? Like in one of the book it is just written regular chest physiotherapy with postural drainage and exercise, prompt investigation and treatment of chest infection, antibiotic prophylaxis if needed, mucolytics, bronchodilators, immunization, nutritional support, and surgical lobectomy if it is not improved. So it's given like just 7-8 points like this. So do we need to tell like this, or do we need to? And no, they have also mentioned
what is your clinical finding that you should in this child, why do you want to do a lobectomy? What is relevant only you should speak. They will unnecessarily put marks down if you say I will refer this child to pediatric pulmonologist and all. So just what is you only found rhinorrhea. So think of allergic rhinitis. Simple.
Not in this case. Not in this case.
No, she's asking if there was a chronic lung disease case, if there was a different scenario. So you have to tailor your management. You have to tailor your management based on the findings you have obtained. So if it is a chronic condition like a bronchiectasis or a cystic fibrosis, and you have sometimes there can be portacath insertion in the chest, which you will only find on palpation. So be mindful of that.
Sorry? Cystic Cystic
Yeah,
fibrosis children will definitely have a border cat many a times.
yeah,
We haven't seen. I don't know about Myra, but I haven't seen Pota cat in my life.
yeah. So there will be a small scar just
Clavicle.
below the clavicle, either on the right or
Okay.
the left side of the chest. And when you palpate, you will feel some device beneath, subcutaneous under the skin.
Okay.
Okay, so
So
where the Portacath access device are. So you can try to Google that up, but it is more than likely that when you get a chronic illness case, the child will be having a Portacath on the chest. You have to,
okay.
and you are expected to make a comment and recognize that in your exam station. So when you get a comment, clinical chronic lung disease patient, so if it is suppose if it's an infant, a premature infant who has had long course in neonatal stay and has suffered and has been discharged with a chronic lung disease with a low flow nasal oxygen, is coming to you at 8 months of age with a new acute, increased work of breathing. So there, that management will be different. Those peak flow and all those adult things will not be included. So in this one, you would be doing an acute assessment. You will do the ABCD approach, get a set of ops, address the acute lower infection, get a chest X-ray, and
Okay.
you would be admitting this child. So your management will be different here. And then again, in the older children with chronic lung disease, those as you listed out, um, you will admit those children if they have an acute exacerbation of infection. You will be admitting them in an isolated room, in a different room, because they and the examiner will be looking out for this point, that would you be admitting them in a general ward or an isolated ward. And then
Why do
you
we put a porta cat?
sorry,
Why do we put a porta cat?
Portacath
Cystic
is for
fibrosis children. Yeah, yeah. Rice bag can continue.
yeah, Portacath is an access device for because they have very frequently they require a venous access, and they most of the time they require a central venous access to administer drugs like vancomycin and prolonged medications for 14 days and 21 days. So that's why for venous access, a central venous access, they put this Portacath in device. They most of the times they have very challenging venous access, and it's not reasonable for them to undergo venipuncture every time they come into the hospital, like every month.
Hmm.
And it's
The
easier to it's
cystic
easier to withdraw
fibrosis,
blood as
yeah, cystic fibrosis children can easily develop ABPA, allergic bronchopulmonary aspergillosis. They might, what do you say, have hemoptysis.
ABPA.
So they need to, yeah. So it's always good to, they can come with the hemoptysis. So it's always good to, what do you say, have a central access to give IV antifungals, antibiotics. Because as Raisbai said, cystic fibrosis children need to be isolated
No, but
because
how can you approach it? You said it's a device that is inside the body, and it is recognized by seeing a scar under the clavicle. So then, do they just open it every time whenever they need an acute?
yeah, they make an incision.
Oh,
There's a separate respiratory nurse for these children, respiratory
okay.
specialist nurse, and
Mm.
they make a small incision. They create a sterile field, and then they get the access, and they attach an additional outlet catheter to that, where they can get the venous bloods and all
Is
the
this the
access.
same like Hickman line? Is this the same?
It's different from Hickman line.
Okay,
so
because we once did a Hickman line. I don't know about Pota.
Yeah,
Provia,
try to look this
Yeah,
on
I have
YouTube
seen
or
the
Google.
pictures on the Google of
Yeah,
Pota
I
cat.
also saw. Hmm.
Yeah, but this is very common scenario in actual exam. Usually,
Okay.
the if you see a teenager, a thin teenager coming in, staying in your clinical examination, it's more than likely that she or he has a chronic lung disease like a bronchiectasis or interstitial lung disease or a cystic
Okay.
fibrosis, and they will have this device somewhere in their chest.
Hmm.
Okay,
Okay.
if you miss this, then it's a
Hello.
major miss in the clinical finding.
Hello.
Hello. Yeah.
Oh. Hello.
Yeah, are you able to hear me?
Yeah, I can hear. Sorry.
Yeah. So
Dr. Ubaid wants to say something.
Hello.
Yeah.
hello.
You want to
Uh,
add something? Ask questions.
yeah, the only thing that actually I just came in from admitting a patient, so I was in the middle. With regards to the respiratory examination, we were told by one of our professors in Pakistan that try to minimize your commands. If you are going to tell him that now sit, lie down, sit again, you would be wasting your time and you wouldn't be able to get your whole examination done. So what Raisbai advised to treat the chest cavity as one. It's better to do everything when they are sitting, and only then to do those things that you need to do when they are lying down. So get everything in one go, and then if anything is left, you do it afterwards. That's the only thing that needed to be addressed, and I think the rest of everything is going fine. I'm just a bit tired, sorry.
Yeah. No, that's fine.
You see,
Yeah,
in a
that's a
chronic,
good comment.
yeah, in a chronic lung disease, right? Sometimes management they might ask how to. Do you know how would you fix a domiciliary oxygen? How do you fix a domiciliary oxygen rate? This has been asked. Okay, in a chronic lung disease child, what are the parameters used and how do you, what do you say, fix it, the domiciliary oxygen rate for such a child? That's been asked for the exam.
Sorry, could you repeat what are you saying?
Imagine you have a preterm who's now 8 months, is a chronic lung disease, is on
Okay.
diuretics and is on
Yeah.
domiciliary oxygen. So you should start your examination by looking at the hands, look for multiple peripheral cannulation marks. Okay, and then if there are nasal oxygen, how much oxygen they are. Then what do you say? Bedside if they have diuretics nearby, and they might have dolichocephalic head, which is quite common for a preterm. Okay, and you basically see. So if it's a chronic lung disease, eventually you could say that this is. It looks like a preterm to me, and I would treat my primary provisional diagnosis as chronic lung disease or bronchopulmonary dysplasia, and you should actually look for signs of what do you say, right heart failure as well, pulmonary hypertension. That's all you need not say, but they might ask if you have a chronic lung disease child that how do you fix the domiciliary oxygen rate? That could be a question.
Seeing the
Okay.
saturations.
Okay. And
So how do
in
we
the
do it?
in the chronic lung disease patient, we also will look for the signs of pulmonary hypertension, and would we see that, would we like say that we would like to do the echocardiography or no?
Yeah, in the management you can say usually they won't keep children who are on right side heart failure.
Okay.
They won't come for the exams. But I would ideally pair that this child has a chronic lung disease and would ideally want to have a regular follow up and see for signs of any right-sided heart failure, any enlarged liver, or
Okay.
as
And one more
as a
question.
child grows big.
Okay. And one more question: if the child is having dextrocardia, so like would we say like we would like to complete the examination, like would we see for the features of Cartagena syndrome?
You will not get a dextrocardia in respiratory station. You will never be getting that. Take it from
Okay.
me.
What
Okay.
You
is the answer? Sorry, what is the answer of the question you were asking? How to fix the oxygen, domiciliary oxygen, something you are asking?
That is a low flow oxygen device, which is I mean, essentially they are testing you if you are aware with that instrument or not, and it comes in different companies and different brands where you are expected to know that how what is like how to adjust the flow, which can range from 0.01 to zero point 0.2.
Okay.
Okay, so you have to make sure what assess with the parents how much the child has been on, like point 0.04 or 0.05, and how much do have they required to go up on. So So it's essentially, it's not too critical for you to passing this station. It's an additional extra marks question. So if you have identified all the rest of the signs of the chronic lung disease of the child who is, um, I mean, with the acute management and the long-term management, these are the additional questions for extra marks. I mean, if you have seen the device, I can explain you. But if you have not seen the device, don't worry too much about this.
Okay.
Yeah. I mean, if you're preparing, like when you prepare for these stations, don't start your preparation from this point. Start to try to prepare from the first with the basics, then go to these questions and go to these points for the extra marks. Okay. So what you have to do in terms of approaching these kind of stations is try and go through the list of the questions, go through the list of the cases that you are expected. So if you have a
Okay.
young baby, you can have a chronic lung disease, premature baby. If you have a middle child, they can have an reactive airway disease or viral induced wheeze or asthma as well. And then you will have to look for elements like atopy and eczema and those things. And if you have an older child, usually more than 8, 9, or 10 years old, and they look quite young and they look quite undernourished, that's more than likely to be a chronic lung disease. You cannot label the diagnosis in a chronic lung disease as a cystic fibrosis per se. You have to mention a broad umbrella diagnosis like a chronic pathology. My list of differentials are bronchiectasis, cystic fibrosis, or interstitial lung disease. And then and the findings in those, in all these three kind of different kind of cases will be different. So what when you are preparing, try to prepare a list of findings and the management you will be getting in all these kind of different case presentations in these stations in the respiratory station, and that's how you will be summing up your. I mean, you would be able to score well in respiratory domain. So be mindful of your structure of examination, and then the cases and the management of that. Any questions with regards to how to prepare for this station?
Uh, I will read about the description of these, and if I found anything, then I will ask you.
Yeah, that's fine.
And one more thing, like I just wanted to say, like today it was a very healthy discussion. So like, can we have like this sort of like, can you guys take 2 classes on the nervous system, like so we can discuss, like, and we can touch all the cases, like how the case uh, can be given, what would be the command. So like we would, like, we have read it, but still we are not sure about 100% about all the things, like, and like we have done the eye examination only in the nervous system. So today we have almost covered everything in the respiratory. I will see if I have some questions from there. Then like cardiovascular and musculoskeletal, because I found musculoskeletal, although it's not difficult, but like we would like to go like because nervous system has so many things, so we can do that in
I
two
get it.
classes. And cardiovascular we can do, I think, 1 or 2 classes, and the remaining like we can do in 1 2 classes. So I think 5 5 6 classes are clinical stations would be covered. And in the communications, like we have not done the ethics thing and education, like there was one case of communication, like you have to counsel regarding the sensitivity and specificity. So if you
Yeah,
could just take our class on that, so that would be great.
yeah, that's fine. So we'll try to
Yeah,
um, I mean arrange a time, and we can give a topic that
yeah,
this is what we'll be discussing, and
yeah,
uh, and
that
whoever
would
wants.
be great.
Yeah.
And what else I would, yeah, if you could do that, then it would be very like helpful for us.
Okay, fine.
Yeah.
So I don't know if you would like to carry on, uh, the other station which I had prepared was the developmental station.
If Dr. Obed will do.
Yeah, I don't know if do you want to do Dr. Obed, or you want to do it tomorrow, or maybe sometime later.
the developmental session would include the whole history and examination as well.
Yeah.
I think I could give it a go. Or if everybody is happy with tomorrow, maybe I would prepare a bit more, and then we could give it a go tomorrow.
I'm not sure about tomorrow because I've got some other commitments. I can do it next week.
Okay, that's fine.
I can do it on Monday if you guys are free.
Because on Monday.
Yeah, it's better to attempt a station when you are prepared. It's your learning process is much more better.
Yeah.
Rather than rushing into things, you will find it difficult to grasp a lot of things if you have rushed into your without preparing. I mean that's my personal suggestion that you approach it this way. And development is the most the longest and the heaviest station of the entire clinical marks wise. So it's important that you are able to do everything, the history and examination.
Yeah, that's why I wanted. Although I have read.
I also want to do the development station, but I tried to learn the things, but I'll try to focus what you told that we should cover like 2 domains from each part. So would like to take development if you have time.
Fine.
The next week.
Yeah, if you're free on Monday, Dr. Obaid, then we can do that, and you guys can join as well, and then we can discuss each domain, how to examine, how to give the instructions, and we can give one dedicated day for that day. Okay.
Okay, and I also would like you guys to take my development as well. On one day. I always say I will prepare, but I'm not prepared for that.
I think if we have got time and the rest of the candidates are also enthusiastic about doing that, then I think I could do it now if everybody is happy.
Fine. So we can try. We can try to do at least. We'll do the history section first, and then we will see. We'll go to the examination after that. So can you? I'll just share my screen.
Yeah.
So if you see this, yeah, can you see this?
Yeah, I can see.
So this is your task that you're working as middle grade registrar at a district hospital. You are asked to take relevant history from Clara, who is the mother of this child who has presented with some developmental concerns. You may ask the questions in the domains of gross motor, fine motor, and social skills. And in your discussion with the examiner, you will be asked to describe step-by-step examination of speech and language assessment. And this is the child.
Okay, and what's the age of the child? Can you?
So the age of the child is not disclosed. Okay. Sometimes they do give the age of the child. Sometimes they don't. Okay. So do you need time to prepare, or do you want to start with the history?
Just give me a minute to make things a bit sorted out for myself.
See, even if you haven't prepared really well, right, just present. So you will definitely make mistakes. Then these mistakes will stick in your head so that, on the day of the exam, you will not make these mistakes. I would advise you to make as much mistakes now so that, you remember all these mistakes on the day of the exam. Okay. Don't think about losing morale or anything. Just read about it. Whatever comes to your mind, present. And if you feel like, I've not done well, you will understand. You can gauge where you have gone wrong and where I need to improve. Unless and until you present, you may not be able to physically, gauge yourself as to where you stand. Yeah. So it's good that, Ubaid is presenting, even though he's not fully prepared.
Okay, yeah, sure, let's go.
Yeah, I will just start the timer, which is
What was the name of the mother and the child? Sorry.
Yeah, the mom. You can make any imaginary name as well. Doesn't
Jenny
matter.
and Williams.
Oh yeah, that's fine. So I will start the timer now, which is 9 minutes. Is it 9 minutes or 10 minutes?
And I am in outpatient department.
15 minutes.
13 minutes.
Yeah. So
14 minutes, 9 minutes discussion.
Okay.
fine. So let's start. 13 minutes. Start. Your time starts now. Yeah. Go on.
Sorry, just a second. And in those 13 minutes, how much time is for examination, or is it all the
No,
same?
this is purely for history, in which you have to get all the history relevant information, and at 3 minutes you would be given, when the time closes by 3 minutes, you would be given a warning bell in the actual exam station, which will indicate that you have just got 3 minutes left to complete your history and summarize it. Okay.
Okay, perfect.
Yeah. So I will just resume the time again now. Yeah. Go on.
Hello,
Hi.
my name is Ubaid, and I'm one of the pediatric registrars here in the outpatient department.
Nice to meet you. Yeah.
Nice to meet you too. Are you Jenny Williams' mother?
Yes, I am.
So Jenny, can you please tell me what brings you here today?
So I've seen my baby, who's not, as with other children. He's not, obviously he's a special child, but I think he's not speaking as he should be compared to the rest of the children. So I just wanted to get him looked at.
Oh, I understand. This must be worrying for you. Um, can I ask age here or not?
Well, I mean, in the actual exam, if the instruction or if they have not given the age, it's not appropriate to ask the age from the role player.
Okay. So you are worried about his speech.
Yeah.
Now, does he speak at all?
So you will be assessing the speech and language in your examination section. So you can't ask history related to speech and language. Do you understand?
Okay, fine.
If you read the task, if you go back to the task again, it says you can ask history from, you'll in your history station, you'll be asking from the rest of the domains, which is gross, fine, and social.
Okay,
Okay.
fine.
Try to get the age in those domains, and the rest of the history, and then you proceed to your examination with the examiner, where you will be assessing how would you be checking the baby's speech and language.
Okay. So is he able to sit?
Yes, he's able to sit. Yeah.
And can he crawl?
Yeah, he does crawl.
Can he stand and walk?
Well, he stands with support, but he is and that is sometimes hit and a miss without support, but he can't walk.
Okay. Is he cruising around furniture and around bed?
No, he's just, as I said, it's more of hit and miss when he's standing without support. But when he holds on to something, then he's able to stand fine, but he doesn't walk.
Okay. And what about is he reaching for objects at the moment?
Yeah. He likes all his toys, and he quite enjoys them. Plays with
Okay.
them.
And have you seen him exchange toys between hands?
Yeah, I've seen that. Yeah, he does that well.
Okay, fine. And by any chance, can he hold a pencil or any object with the tips of his fingers?
Well, I've seen him picking up uh, his grapes when I offer him food, and small beans. He tried to pick that up with his fingers.
Okay. Is it more with the top of his fingers or with the tip?
With the top of his fingers, with
Okay,
with two fingers. Yeah.
that's perfectly fine. And what about his eye contact, and is he able to maintain eye contact? Or are you happy with that?
Yeah, he does maintain eye contact. He um, I've no concerns with that.
And does he have any anxiety from strangers?
Well, he's quite a playful child. I've seen him enjoying and playing with other people. I mean, he's quite a lovely boy, you see.
Okay, fine. Now, coming to your pregnancy and birth, how was your pregnancy?
Well, it was uh, I mean, quite normal pregnancy, to be honest. Everything was fine.
Did you have your scans, and what did they tell you
Yeah,
about your?
yeah. All the scans were normal, and nothing. I wasn't informed anything during the pregnancy. I wasn't told anything wrong.
Okay, and you had your follow-ups with gynae and obs, and all of them were fine.
Yeah, yeah.
Okay, and how was his birth?
So it was a normal delivery. He was born at term gestation, and soon after he was born, we were informed that there was that he's got Down syndrome.
Okay, oh, I'm really sorry to hear that. So what did they do for that?
Well, they conducted few bloods, few tests, a long series of tests. I don't remember exactly, and then they've. I'm also waiting for some other specialists consultation, but I've not heard anything back yet. Now.
Okay, and what did they tell you about this condition and all?
Well, they said it's Down syndrome, and they explained me what it is, and that he may be needing additional needs, um, and so we are just following up with our pediatrician, the doctor at our hospital. Um, so I understand that he is waiting for appointment with the heart doctor, and then also with the doctor who is I mean with some physiotherapist as well. But I haven't been there yet. I haven't heard anything. And he is also seen by the dietitians on and off. Um, yeah.
Okay, and just asking, are you satisfied with his hearing and vision?
Well, that I've had concerns with his hearing. They when they did the hearing test when he was born, they said they need to repeat it at some point, and so I'm waiting uh, for that appointment really.
Okay, so other than that, than the Down syndrome thing, how is he generally doing with his health?
Well, he's quite good. He's a happy child to be around. He likes his food. He's not too much into eating much of fruits, but he does like vegetables, and he's otherwise well child.
Okay, and till now, has he had any appointment with any pediatrician or any other allied health profession?
So he's had we regularly see his pediatrician at our district hospital. And the other professionals who come to visit us are um, uh, the dietitians, and we've also had occupational and some physiotherapists as well.
Okay, and how is he coping with physiotherapy and all?
Yeah, he seems to be fine, and he does enjoy his sessions during the visits.
Okay, perfect. So, is he on any drugs at all?
Yeah, so he is um he's taking his thyroxine tablets every day in the morning.
Okay, and was he screened? When was he screened for thyroid?
When he was born, and then they repeated that at 3 months of age. They said his thyroid was quite low, so they had to start him on thyroid supplements.
Okay, And how is he generally doing now with his bowel movements and his wee and everything?
Yeah, that's all right. No issues there. He opens his bowel regularly, and he he passes. I mean, he has regular wet and dirty nappies.
Okay, and with regards to his immunizations, has he received all the vaccination jabs?
Yes, he has received all the. He has got all the vaccination for his age.
Okay, and is he known to have any sort of allergies?
No, no, he doesn't have any allergies.
Any, by this I mean any allergy to any medication,
No,
dust,
no, no,
mite, anything?
no,
No. Now, any family history of any major medical illness?
no, no.
And um, is your partner by any chance related to you in terms of a family relationship?
No, no, no.
Okay. Any problem in family with developmental delay or learning impairment?
No, everyone has been fine. Everyone's been all right.
And is he your first baby?
No, so this is my third child. I've got a 8-year-old and a 5-year-old, 8-year-old girl and a 5-year-old boy.
And how are
And
they doing?
they are all good. They're all good.
Okay, perfect. So now I would like to assess him.
What's the time now?
Yeah, another 2 minutes. 2 minutes left. Although the warning sign would have been given at 3 minutes time, but you've got 2 minutes, and you can now start. If you've finished your history, you can summarize.
Yeah. So um, I okay.
So in your summary, you try to what you've gathered
Yeah.
your information, and you try to give an estimate age on based on your history.
Yeah. So I talked to William's mom, Jenny, who is concerned with William's speech and language delay, and on assessment. His age, his chronological age now is up to 1 year, around 9 to 1 years, 9 months to 1 year,
Okay.
and he he has Down syndrome, which wasn't picked antenatally and picked at birth and was confirmed by blood tests. He also has a thyroid. He also has hypothyroidism for which he is receiving thyroxine.
Mm-hmm.
Uh, and the rest of systemic review and is all right. And that's it. Yeah.
Yeah.
Ideally,
Yeah.
I would like to examine him and plot him on centile charts appropriate for Down, and like to assess his speech and language directly.
Okay. So we will go through that in the examination section. So yeah, just another 20 seconds left. So I will stop that now. Yeah. So that was yeah. How did you feel that in terms of
Um,
your history? Did you feel if you needed to get more information or and how
I think
what would you do?
I didn't ask questions with regards to the associations and complications of Down syndrome. Um,
Okay.
Although you told me a few yourself, and
But were you able to identify that it was a Down syndrome child based looking on the image?
yeah, I was there. Yeah, I knew that this is a Down syndrome case, and
Yeah,
I
because
was
that was
looking for the
quite
antenatal
obvious.
scans
Yeah.
or the triple test. And then you told me at birth. That's why I brought in the birth history a bit earlier, uh,
Mhm.
so that I could be on. I could put myself on a line towards taking a focus history for Down
Okay.
syndrome. But
Yeah.
then I don't know, somehow I lost the track, maybe because this is not a face-to-face communication, and I didn't ask about thyroid or any, although I asked about bowel movements, and I didn't ask, but I picked the thyroid thing you told me in drugs. I don't know if they would be that generous or not. And
Yeah.
what
So
you told me that he had an echo, but I didn't
no,
explore that.
I told that he will be having appointment with the cardiology later on.
Okay. And
Yeah.
then I explored the social services, but right now, as the child's age is around 9 to 1 month, 1 year, I don't think that he would be getting, he would be in school, or um, yeah,
Yeah.
and that it's early to pick something and to act on that. And then you told me that I couldn't take speech and language history. I would have liked to explore his ability to babble, and then challenge it a bit upwards,
Yeah. Yeah.
to be words and then to sentences, wherever he would stop. So then I would assess
Yeah, so
that.
we can discuss that in the examination how we would be taking the speech and language. But just coming back to the history, I think that was a comprehensive history, I would say. Although I would just like to tweak some bits here and there. So when you've introduced yourself, you've asked the initial concerns. You can either start right from the beginning that if there's any problems with acute presentation, acute illnesses, or you can start from the birth as well, and then you work your way up to developmental history, or you could do as you said, or you could start with your developmental approach as you did. So just try to give when you started it, I was for maybe a role player may be a bit surprised of by asking in the when you're starting which way, whether you're starting the proper medical history from birth, or you're starting the developmental history. So it would be a good idea to start give a kind of introductory caveat that right. So can we just check the so I understand you have concerns with the baby's hearing and speech, baby's speech. So can we just check the other things as well? So in terms of his gross motor, how is he doing? How does he move from point A to point B? And when they give you the movement, you know that at least he's moving. You don't have to go down backwards. You can then work your way up and then try and establish where you have to stop. You have got the gross history. Then you go to do the fine motor history, which you have also done well. You were able to identify the age very spot on, very appropriately, which is actually 9 to 12 months. You have to give in the range of 3 months at least. So try to ask your questions based on the 3 to 6 months differences. So gross, fine, and the social skills. In the social skills, I would have explored a bit more in terms of so you can ask toileting, feeding, how is he feeding, and the interactions with the, I mean, social smile, interaction with the mom, and then interaction with the other children. So this is exceptional because the child is trisomy 21. They do not have, usually they do not have stranger anxiety. And so that can be a bit different. But this is how you would be approaching your history in the in terms of extracting the developmental quotient or the developmental age in each domain, and then going to the actual medical history. So antenatally, this was not picked up. It was picked up postnatally, and postnatally. So I gave you the information on the thyroid when you asked for the drugs, but when such kind of histories, usually the role player will be expecting explicit questions that does he have any other medical condition. Even if you ask a general question that does he have any other medical condition, they should be able to give you that. So you have to explore comorbidities, like in Down syndrome, it could be hypothyroidism, morbidities associated with the heart lesions, or the morbidities associated with the any other system like hematological problems, or hearing problems or vision problems or associated epilepsies and things like that. So once you have explored the comorbidities, then you have rightly explored the professionals involved and what kind of input he is having and how is he tolerating that. In terms of social history, I would go a bit more deeper in terms of extracting how are parents coping, how it has impacted the family, how it has, because that will be part of your management plan, that they will need a family support as well, any social service is involved or not. And then you and the rest of the things are more of tick boxes, allergies, any kind of immunizations and things like that. Yeah, do you want to say, Doctor?
Yeah, I just wanted to add. Yeah, I just wanted to add, like, Down syndrome children very often have glue ear, so they have ear infections. So that could be another reason why the child is having hearing loss, and that is leading to speech delay. Whenever you have a speech delay, you should always ask the history of bilingual languages spoken at home. This is a very impressive question, and they'll be really impressed that you have asked this question. Yeah. And Down syndrome children, another thing is to just bear in mind that there's a lot of social concerns. Many Down syndrome children get abused. So even though it's only 1 year, you should actually dig deep in the social history as well. And regarding school, you can ask if the child is going to nursery.
Yeah.
Yeah. So your history was really good. You actually did a really good job, but we just wanted to, polish you and make you score maximum marks. So you actually got the other domains spot on, and you tried to cover everything pretty much. But we just wanted to, put more tweak your history and fetch you more marks. Okay, so you've
Yeah.
done really well here. But if you add these things, it'll be really, really good. And this station, if you get really good marks, then you're almost you're halfway. Like, you've done really good in the exam. This is what they basically look at.
Yeah, if you can see this screen, I'm just sharing. I've shared this document with Aisha and Myra, so I can resend that document again. So essentially, in the history domain, what they are expecting you is to get the etiology of the condition, which was quite clear in this one. But in the other instances, you have to get these things like perinatal history and prematurity or things like this. Past history, any previous hospital admission, so that will give you any other associated conditions. And then family history of developmental delay and things like this. You have already explored this. Associated comorbidities, we have discussed in this particular instance what will be the specific associated comorbidities. Impacts on child's difficulties, any support, additional help being given. If it's an older child, if they need any education plan, if they need special needs school right at the moment or later on, and the other professionals involved. And these are, when you come to the developmental history, so these are some general questions to be this can be quite handy in terms of getting your information, like have you got any concerns with vision or hearing, which you did ask. Have you got any concerns with movement of the child being clumsy or falling? So this is more relevant to a spastic or a diplegic or a hypotonic child. Have you noticed any unusual movements? Have you noticed any of the body part moving less? So these are some extra bits to make a note of, and then we can discuss the examination. So it's time for. I mean, it's Maghrib time here, so I was just planning to uh, stop the station here and then probably do the examination in the next sitting. Is that all right?
Dr. Rais, could you please tell me what is EHCP?
Which
Early
one?
childhood something.
Early healthcare.
Early, sorry?
Early healthcare plan.
Early healthcare. What is early healthcare plan?
It's a sort of multidisciplinary team involving occupational
Okay.
therapy, physiotherapy, psychologist, a community pediatrician, which get the child is referred or the baby is referred at very early age, like just post in neonatal age, and then they follow them and see how
And
the
who creates this plan? Is this the the consultant makes this plan, right?
if there is any need for that, then they just simply refer it.
It
Okay.
is usually made by the multidisciplinary team in the hospital, where the, like, for example, if the child is identified as trisomy 21 in the when the child is born, they will make a list of referrals to all the teams right before the discharge of the hospital. And then they have this multidisciplinary team, or the pediatrician, community pediatrician in charge will take care of all these referrals and making all these plans.
So
Okay,
the
and I have two
EHCP,
more questions. I have two more questions.
Yeah.
I just want to
First,
add EHCP, right? EHCP,
yeah,
why
yeah.
is EHCP made is because the council in which you have to fund for your school, special needs in the school. So you have an early health care plan, you can alert the council in which you're living. The council will provide amenities and salt referral and things like that. They will arrange everything because they need, these schools need funding, and this EHCP plan, if it's there, the council will provide all the money for support like DLA, disability living allowance. Everything will be arranged. So you have to be in an EHCP plan. If you're not in that plan, the council may not fund for all this. So it is important that such children are given EHCP plans so that the council funds for everything.
Okay, and three more questions I would like to ask. Sorry. First of all is like for the Down syndrome, like
Yeah.
we do the karyotyping, and what else test we do for testing, which comes like quickly, which is reported in 2-3 days, because I think karyotyping takes 2-3 weeks, right? And there's another test, if you could tell me.
In my setup, we expedite the karyotype from the genetics department,
Okay,
and
okay,
then
that's
then there is the I mean I think there is one test assessment where they do the I'm forgetting the name. I'll give you that name, but we are not used to doing that test here. We do the karyotyping, which is expedited because it's a tertiary center here. So that's what I'm aware of.
okay. Okay, thank you. And two more questions. Like we do screening on the first day of the neonates, like first spot, and on the fifth day. So what diseases we cover? Because no one has told us. Like we just do the bloods, and I
There are
wanted to know.
eight or 10, eight diseases. You could cover almost 26, 27 diseases, but I think in UK and Ireland they cover eight diseases: phenylketonuria,
Okay,
MCAD, cystic fibrosis.
okay,
Um,
and also is it also that cover? SCID is also covered in that, or no?
SCID has
SCID.
been recently introduced. SCID has been recently introduced in the middle of this year now.
And the day 5 testing, which we do, that is called the Guthrie test, right?
that is the
Yeah,
heel Guthrie test. Yeah.
Yeah,
it is
there is
it
there, there, there is no day one test, only day five test.
day 5, and
Day
it is done on a Guthrie card, but it's called blood spot test, and you can get this in your communication scenario to explain what is a blood spot test.
zero मिलेगा उसमें. We will get zero after doing lots of screening even because we don't know.
No, no,
We will
no.
just
Even if you do not know the list of diagnosis which we pick up in a day 5 in a blood spot test, you can still score good marks if the questioner, sorry, the role player asks you what are the things we are looking for. Even if you are able to recall 2 to 3, you if you are being honest, instead of giving a false information, you say I will check on this and I'll get back to you. That's the way to go about in case you are caught off with information which you do not know. But if you give, suppose if you give for example, we are checking for very long chain fatty acid disorders, which is actually not being tested. So then you would be marked negatively for giving a false information. But if you
okay.
say that, if you are honest that, so as far as I'm aware, we check for phenylketonuria, we check for congenital hypothyroidism, we check for SCID, but there are a few more tests which I'm not aware of at the moment, but I'll have a look at it and get back to you. You will not lose marks by saying this, okay? You still have chance to pass. So be mindful of these things, small things, but this actually play a big role in determining your passing and failing.
Okay. Okay, thank you.
Yeah, you can get a very rare drug to explain what is that drug, and you do not know the mechanism. If you're honest, you can still score marks there.
Okay, and just one last question, Dr. Rais. Like in the developmental station, do we have babies, real babies, or just the examiner
No,
will?
no, no. You have role player based, for from whom you would be getting the history, and then you
Okay.
would be describing the examiner step by step how you would be actually doing the examination if you had a real baby.
Okay,
So
so
that
like it would be the same. Like if there is no baby, then we were still asking the question. We are not doing it, right?
no, no, no.
With the
And so
baby.
it's I think we discussed this last time. It is quite challenging and different to compare to the rest of the stations. So you cannot. I mean, your approach in your describing examinations, for example, if you're checking for gross motor, you cannot ask, is the child moving, is the child walking? You cannot ask those kind of direct questions to the examiner. What the examiner is expecting you that I will introduce myself, wash my hands, build rapport with the patient. I will get down to the level of child, and I would like to see the child how is. I mean, you do the first bit of examination, and then you do the gross motor assessment. I would like to see what the child is doing now, and I would instruct. I would place an interesting object at this distance, and I would see how the child is moving towards that object. So what actually you would be doing in your real life scenario to look for if the child is moving or not, you have to describe that out in English language in your exam
Okay.
to the examiner. Okay.
Okay, got it. Okay. Thank you so much for answering questions.
Yeah, no problem. Okay. So yeah, I will. I'm sorry, we have to stop the station now, but we'll catch up probably on Monday if everyone's free, and we can continue with this station, and we'll go through how to describe examination in all the domains. Is that all right, Dr. Obed?
Yeah, and at which time on Monday?
We can. I'm free after 5 p.m. So if everyone's
I have night shift on the night on Monday. So
yeah,
if you
so I
guys
can
can
I can
take
do
on
it.
Tuesday, if you guys can take on Tuesday, that would be helpful, please.
Yeah. What about Dr. Obed? How does it suit you?
Um, uh, I think on any day, but a bit late because
Yeah, because I think Myra doesn't have the shift at night as well on Tuesday, and I will be post
Okay.
night, but I would be able to catch you guys around 6, 7, whatever you say.
Yeah,
because in
that's
all
fine. No problem.
fairness, Raised by I was more exhausted than not knowing the history.
Sorry.
I was more exhausted than not knowing the history or the questions.
Yep.
Yeah, I was blocked. I was very exhausted because today
No, no, but
I just got a very sick patient through the end of my shift, and this could happen at any time in NICU as well.
Mhm.
And I will be in NICU on Monday and Tuesday. So if we could do the session, I think Maghrib is at 9.
Yeah, it's
Maghrib
at
is
8:30 here. 8:30 here in
8:40.
the Bristol. Actually, I'm in Bristol.
Okay.
Room 1
We,
is baby born or
so if we could do that at 7, so
okay, I'm coming. Okay.
Yeah,
we
that's fine. No problem.
could
We can try to meet up
Okay.
in
Okay, I have to
7
attend the
p.m.
delivery, so
Yeah, yeah, yeah. Don't worry.
okay, so
Carry
if
on.
you guys can do on the Tuesday, that would be great, so I can also attend the session,
Yeah.
please.
So Tuesday 7 p.m. We'll try to do 7 p.m. Tuesday. All right.
Yeah, inshallah, inshallah. Thank you so much. Jazakallahu khaira. Okay, take care.
Bye.
Allah Hafiz.
Okay. So.